All right, welcome everybody to the third Cinderella webinar. Welcome back to all of you who have already joined the first two Cinderella webinars, and also warm welcome to those who are joining us for the first time today. My name is André. I'm with the Breast Center in Heidelberg, and I'm your moderator today together with my colleague Baiju from Kakadu. Baiju, I'm really excited that you're here today. The both of us will moderate this session. Thank you. Today's webinar is entitled The Cinderella Web, a digital health tool to improve the patient journey in early breast cancer. And while the first two Cinderella webinars have mainly focused on the project from a clinical perspective and from a patient perspective, today we really want to focus on the AI and digital health part of the Cinderella project. So I'm really excited to discuss this with you today. For those of you who are not familiar with the Cinderella project, Cinderella is a project led by Professor Maria João Cardoso at Champalimau Foundation in Lisbon, Portugal. It's funded by the European Horizon program, and it aims to improve the expectation management regarding the aesthetic outcome of women undergoing local regional breast cancer care. So as part of this project, we're evaluating the use of an AI-based digital tool, the Cinderella App, which shows women how their breasts might look like after breast cancer surgery and radiotherapy. Could be either breast conserving or mastectomy with reconstruction, in order to better deal with the uncertainties and the expectations regarding the aesthetic outcome many women face when they undergo breast surgery. For today's webinar, first we will have three presentations, 10 minutes each, by three amazing speakers, and afterwards we will have a panel discussion with our speakers and panelists, and of course, our audience, you guys, for another 15 minutes. And then the webinar will end at around 4:30 European time after 90 minutes. Please, important, use the Q&A function here in the Zoom call. If you want to ask questions throughout the presentations, or especially later in the panel discussion, we will collect them and answer them in the panel discussion, okay? We won't take any questions during the presentations, but in the panel discussion later on. And please use the Q&A function, not the chat, because we cannot monitor the chat correctly, okay? So please use this Q&A function. All right, without further ado, I'm excited to introduce our first speaker, Miguel Romariz. He is the assistant researcher with Inestec in Portugal. And he will be telling us a little bit about the deployment of artificial intelligence algorithms for clinical routine, the Cinderella case study. Miguel, we are excited that you're here. Thank you so much for joining us. We're looking forward to your presentation.
Thank you, André. Hello, everyone. Good afternoon. I'm here joined with Helena, Mohammed, and Tiago, who are my colleagues from Inestec, and we all together developed the algorithms and we developed the Braille AI platform that I am going to present here in my presentation. So what is the Braille AI platform and how it integrates with the Cinderella project? So Braille AI is an online platform with the main goal of streamlining the acquisition of breast cancer patient data and photographs. So with this data, we can develop more algorithms, and we can also test and validate them. In this platform, we acquire biometric information, so height, weight, bra size, and bra cup of the patients. And we also acquire radiotherapy and surgery information. Then, with the assistance of some algorithms, the clinicians can annotate the images gathered of the patients and classify the outcome of the aesthetic outcome of the surgeries. This platform allows the registration of various users from different institutions, which is very important since we can gather a multi-center information and build a robust database. The users can create their own teams in the platform, and each team is individual from each other, and patients from one team are not shared with the other teams. This helps us keep some privacy of the patients between institutions. So why is it important for gathering multi-center data? Well, firstly, it enhances generalization, meaning that with data from various institutions, we have a lot more samples, and we can have edge cases and uncommon cases that help us build robust algorithms. It strengthens validation, so data that we train our algorithms on, and our algorithms can be used on data that they have never seen, and this helps us measure the performance of the algorithms. And we can optimize our algorithms because by identifying universally relevant features in the database, we can discard cases that are very specific and less significant. So currently in the Umbrella AI platform, we have 6 algorithms that are deployed. We have an endpoint detection algorithm that helps annotate the images. We have the classification algorithm that gives us the score of the surgery. We have a retrieval algorithm that gives us similar patients to a given query patient. And then we have 3 morphing algorithms that try to change the photograph of a query patient to the transformations that the surgery has on the patient. So first, the endpoint detection model can be decomposed in 2 parts. First, the prediction of the endpoints, which are the points closest to the armpits, and the detection of the nipples and the sternal notch. So the first part, the endpoints. These are 4 points, the ones in the armpits and the middle, which is in the middle points, which are typically in the middle of both of the other points. And with these points, we can extrapolate the contour of the breast by running a shortest path algorithm through the contour of the breast. And this gives us a whole view of the breast that can be analyzed by our algorithms. So here you can see some examples. So the red points are the ones that are automatically detected, and the white points are extrapolated by the shortest path algorithm. This gives us the necessary inputs for the classification model, which analyzes the breast contour and do some calculations on the asymmetry, the difference in the color of the breasts, maybe some scars, and gives us a classification of the outcome of the surgery in excellent, good, fair, or poor. Then moving on to retrieval. So the goal of this model is to find in the database the most similar patients to a given query patient. In order to achieve this, we have clinicians. Firstly, we have clinicians order catalogs so we can have some data that we can analyze. Then, using an AI model, features are extracted from the query patient, and using a similarity metric, we compare the features of the query patient with the patients in the database. Then the model will rank the patients according to similarity, and if the model doesn't reflect the choices that the clinician made, we have them run again. The process runs again until the model learns to imitate the clinician. In the end, the model should be able to mimic the clinician's decision-making when finding the similar patients. From here, we have an example. So on the left, we have the query image, the patient that will come into the hospital. And then we have the retrieved patients from the database. On the left, the excellent and good cases, and on the right, the fair and poor cases. Moving to the morphing module. So the goal of this module is to try to transform the image from the query patient by applying to it transformations that the surgery may have on the patient. By combining this module with the retrieval, we can have patients that have similar bodies and similar features, and the transformations are more realistic. So currently we have 3 modules. The first one is a conventional computer vision method. This does not use AI. In this module, we get the key points from the pre-surgery photo of the query patient and the post-surgery key points of the retrieved patient from the database. Then we calculate the asymmetry features of the post and the post-surgery patient, and we try to reallocate the key points of the post-surgery into the image of the pre-surgery patient. This allows us to transform the breast contour and try to have it mimic the transformations of the surgery. Then we have the first AI module, where we train the model to identify different characteristics in the photographs. So these characteristics are identity characteristics, such as moles or some coloration in the breast. Then we also try to detect asymmetry characteristics, so differences in one breast to the other that may result from the surgery, and other characteristics such as scars or bruises that may also appear from the surgery. Then we generate a new image with a generative model with the identity characteristics from the pre-op image and the other characteristics from the post-operative image. This allows us to generate an image with the body of the pre-surgery patient, but with the transformations of the post-surgery patient. The other morphing module is the in-painting module, is also AI. And for this one, we try to, the first step is to hide the breast that we want to transform. And then we get our retrieved patient and we calculate the asymmetries and we put the nipple and the lower point of the breast in the image of the preoperative patient. And then we generate only the breast that was transformed, as you can see on the right side. So here we have a comparison of the three modules. They all perform reasonably well. The conventional method may be more realistic, but in cases where the transformations are have more impact, sometimes the images are a little bit warped. But yeah, I think all three methods result very well. So how are these algorithms implemented into the Braille AI platform? So the Braille AI platform is comprised of two systems that communicate with each other, the front end and the back end. They are both deployed in different machines and talk with each other. The user only interacts with the front end and the front end sends requests according to the needs of the user to the back end, which sends the replies and shows the information on the platform. All of the modules are deployed into their own containers, so we can address them individually, and if needed of maintenance, we can bring one down without impacting the system as a whole. And this modular approach gives us easy maintainability, as I said. It can improve performance since the modules are not loaded all at the same time, they have their own instances. And it gives us security because only the front end is exposed to the end user. So even if that machine is compromised, no information is saved there, and everything is saved on the backend server, which is more secure. So how does the Braille AI platform help in the Cinderella use case? So in the Cinderella app, whenever a new patient is enrolled to the trial, it is automatically synchronized with our platform through our API. And then the clinicians will annotate the image in order to have in order for you to have the information about the breast contour. With this, we can run the retrieval module and the morphing module and send back all of the similar patients and all of the possible outcomes for the patient. Then the clinician would choose the images that best representative of the case, and they will show them to the patient, the good outcome and the bad outcome. And with this, we can manage the expectation of the patient by showing them the possible outcomes and the very best case and the very worst case. In the future, after the 1 year has passed from the surgery, the images of the patient will be uploaded again to the platform, and we will give the score of the surgery of the patient. Well, this marks the end of my presentation. Thank you very much, and I'm excited to answer all of your questions in the end. Thank you very much.
Thank you, Miguel, for this great presentation. It's always a pleasure to see how this algorithm, how this project evolved from matching up pictures to now actually morphing up those patient images. It's really exciting. Please, for the audience, please submit your questions to the Q&A part. We will answer them as part of the panel discussion later on, okay? Now it is my pleasure to introduce our second speaker today, Professor Timo Schinköthe. Timo is a professor in digital health, as well as the founder and CEO of Comcator. Timo, we are excited to hear about how to implement AI applications in routine medical care. The stage is yours.
Thank you, André. Thanks for the introduction. And yes, pleasure to be here. And just to compare to our beginning, we have 4 degrees currently in Munich, which is a little bit below Athens. Yeah, so thank you. My topic today will how to implement AI. We had a very interesting introduction from Miguel, our presentation, where he looked deep into the algorithm, but I would like to look more from the clinical point of view. And of course, we need some solution where the doctor needs to sit still in the driver's seat, because everything what is doing or what will be done with a patient is in the responsibility of the physician. And let me just summarize very simply what Miguel explained. So we start with taking a picture. Next step is that the AI is analyzing the picture. It will generate some collection of potential forecast pictures, and these will be presented or shared to the patient. That in very general is what Cinderella is doing. But here the doctor is missing from our point of view. And what we wanted to add is like a review process before, to make sure that everything is which reaches the patients is under the control of the physician. Why we think so? The reason for that is maybe the pictures who are shared to the patient might be too disturbing, or in the other way around, they might lead to an too optimistic view in the patient expectation. And we also thought that whatever comes from the AI needs to be moderated by an expert before or when shared to the patient, because as I said before, the full responsibility for the patient will keep in the hand of the physician. Here is a screenshot of how the implementation from Cinderella looks for the doctor. And everything starts with the pictures from the patient itself. In that example, there's just a single picture uploaded. And from there, then the next step is that the physician has to select which kind of surgeries might be applicable in the individual patient, because the predictions or forecast will depend on the type of surgery possible for the individual patient. Next step is then the presenting the collection of potential AI pictures to the physician. And from here, the doctor can decide, okay, which are pictures I want to share with my patients. And as Miguel also showed, in the algorithm, there's this grading of excellent, good, regular, or poor, and that's also shared with the pictures here to the physician. From there, now starts the review process, and the doctor decides which pictures should be and can be shared to the individual patient. So it means we have here first the full selection of all pictures available from the AI system, and then on the right hand side the pictures selected by the doctors which will be shared to the particular patient. Next important step in the Cinderella project was how to present the pictures to the patients and how we want to develop the Cinderella patient app. And as you can see here, that was a picture from our workshop. It was really a hands-on workshop where we all together tried to identify and to develop the concept for the patient app. One very important question for all of us was the question, do we all share the same patient? Do we know that our patients are comparable? So all these 5 countries, I mean, we have in different locations, we might have a different cultural background, and therefore probably can also have different patients. And to understand which patients we have, how they are thinking, we used a tool which is called personas. Personas is something introduced initially by Alan Cooper some years ago. It was the idea to help and support initially in software development, but today is mainly used in marketing to get an understanding of the target group. And the meaning is you develop an individual person which gives you a fictional picture about his background, his demographics, maybe his health conditions, education, and so on. By using these things, it can help you to focus, to emphasize more to concrete persons, to improve your decision, to communicate also during the development process, and it streamlines your efficacy. And that's what we did in our workshop. So we developed several personas, we gave them all name, and during our development and workshop, we called them according to the name of these fictive personas, which we defined together in the workshop. So the key findings while talking and working on that and discussing using these personas was that we need a companion content. So just only the pictures will not be enough. There must be more telling to the patient, giving useful benefits, which helps the patients to understand the whole situation. But then, of course, the pictures must be shared in the patient app, and also the grading needs to be there. And they should be able also to compare their own pictures, which was made in the hospital, compared to the AI images. When we talk about a companion content, it includes the disease, the surgery, the treatment, the rehabilitation, but also very important, frequently asked questions. On top of that, what we realized was that we have different types of patients which wants to have their information with different levels, with different gradings. And so there are patients who needs very detailed background. They really want to understand what is there, what it means, to get also trust in the app and to learn as much as they can. Then there are some, let's call it median users who wants to have information but not get too much stressed with too many details. And then there are patients who just want to have a few idea of low need for information. And we did that, as you can see on the right hand side on the screenshots, as we use these top buttons with simple, normal, and extensive. And that means the patients were allowed to switch between these 3 levels of content depths. Putting together what we learned and what we did and how we implemented and what is currently in use in the Cinderella clinical trial is, from our findings or ideas and thoughts, the AI must be implemented to support the doctor. And the doctor must keep control over the AI, because at the end, the doctor is responsible for the particular patient. And the patient should not be left alone. So just providing the projections is not what is, from our point of view, beneficial or useful for the patient. And just the projection will also be not enough. We need to have a companion information surrounding the AI prediction. And we have different types of patients who have different information needs, and these must be also reflected in the application. And what we interesting find out when we made the personas, all of us from all the different countries, we had some patients in mind where they say, yes, I have these kind of patients. So at the end, also with this different cultural background, we are sharing the same patients in these 5 countries. Thank you very much. And I'm very interested later on to talk with all of you together.
Thank you very much, Timo, for this amazing presentation. Again, please ask your questions in the Q&A section. We will answer them later. I will definitely come back to the statement that the doctor must keep control over the AI. We will have to discuss that. But first, we are going to Henrique Martins. Henrique is a professor in digital health management, and he will be talking with us about to use or not to use AI in breast cancer. Can ethics help? Henrique, we're excited that you're here today with us. Please.
Thank you, André, and thank you all. Very quickly, I guess not significant conflicts of interest. Working in the project on the aspects of data protection and ethics, and sometimes people ask, is there one ethics or many ethics? And I always remind one of my ethics professors saying everyone has its own code of ethics. Now, the reality is people are always looking for a code of ethics, but ethics is an exercise of reflection. And I'm not here to preach about ethics, but rather to try to bring to the audience the idea that, well, first of all, within the Cinderella project, we're not taking the usage of AI lightly, the enthusiasm of the technology, but always with a reflective perspective. And that is what I believe is usually key to understand. Well, this diagram is just a simple representation that what is mandated by law required, right, limits our spaces of ethical reflection. What is possible by technology also does. If something is not possible, well, then there's not really an ethical issue. And then what is morally desirable. And within the Cinderella project, one of the things that is relevant for everyone to follow is that we have different backgrounds from different countries, different cultures, and to some extent, different cultural and moral tradition. And if we zoom out of the consortium into the world, that even becomes more complex. So, if you look at this diagram and you reflect on the law, something like GDPR or fundamental rights, technology is relatively available or homogeneous around the world, although that's not always the case, but assuming that is the truth, then the moral desirable realities are also not the same. So taking this reflection from an EU-funded project to the world, many people that are listening to us may not be from where our partners are coming from. It means that we need to think of it broader. But at the end of all of that, it doesn't mean you can do it. or you should do it, or you want to do it, or that you feel okay doing it. And doing what? To use or not to use AI. So that is the question, and I set myself to contribute to the reflection. And many years ago, well, not that many, but a few years ago, I read this very interesting article. It's actually a 72 pages article written by a lawyer about AI-based medicine, which doesn't quite interesting. And he calls it black box medicine, to this sort of new personalized medicine. So a few years ago, we were talking about personalized medicine. And of course, as you've heard the last two speakers, I mean, Cinderella is definitely a tool, an approach for personalization of medical care. That is no doubt. And the question that that this author presents is, okay, but is it explicit or is it implicit? So can we reproduce the model? Can we understand exactly what happened, what led to a certain prediction? And as you may imagine, some AI models are more explainable than others. And we in the project are also discussing and working in that space. There will be a webinar, that's my time for it. There will be a follow-up webinar looking at explainable AI in the Cinderella project. But to advance on this, this is a sort of a very small provocative diagram. If you imagine that pulp dust and computing power has been raising since early days of medicine, with Hippocrates and even before to today, so it's easy to understand data is accumulating and we have more. It's also easy to understand that the first doctors were sort of magicians, so they would base themselves on the human experience. And then we went into a more scientific period of medicine where we have papers, guidelines, drug indications, classifications of diseases, classes of patients. So a patient is to be put on a certain small group. And if you are right in putting it in the right specific group, you have the right specific treatment. At the end of the last century, we started talking, well, that's not enough. We need personalization. We started computing many data about one patient. And this is the area what I call digital doctors. So doctors no longer can do this. And Timo was saying that AI needs to work for the professionals. And definitely, even before AI, we used to have simple calculators, then more complex calculators, because there was no way you could, for example, compute all the genes and all the variables that you need to take into account to decide the treatment in cancer. And now we are moving to implicit personalized medicine. So we have certain predictions based on AI that might be right, but we don't completely know why we got it that way. And this is what I call robo doctors. Now, the reason I like to present this is because, you see, in the early days, we didn't know how the magician did it, and maybe it worked. And now we might also not know how the AI does it, but it also might work. And so we so many years working so hard to get to the same magic outcome. Well, maybe not, I think. But in any case, who uses AI? And is it oncologists? Is it the patients? Is it all of them, or even the family? And I just remind myself that this very simple thinking about leaders in the digital world is quite useful. Thinking about people, so deeply understanding people, digital organizations, so digital medicine, and then the interest of the technology. So we have evolved this tool, and the question that is an ethical question is, are we also getting our oncologists, our surgeons ready, and our patients ready for this type of tools? And is it ethical to give them a tool for which they're not prepared? And I guess this is why we're doing these webinars, is that we want to not stop using advanced tools. just because people might not know how to use them. So this is important. And it's not just me saying this. A few years ago, when I participated in this effort with the Ministry of Health in France, there was this first reflection about what could be ethical principles on digital health. And in a nutshell, this is available online. These are grouped around 4 areas. Digital health with humanistic value, enabling individuals to manage their digital health and data, and make digital health inclusive, and the dimension of responsibility, eco-responsibility. I'll focus on 3 very quickly to just highlight 1 or 2 of these principles and how it means something to us also in the project. Digital health complements and optimizes face-to-face health. So by no means the project and Cinderella App, I believe, is to be used in itself, in isolation. It is to complement, it is to optimize face-to-face experience. It is to be used together with someone from the family. Now, individuals are informed about the functioning of the digital health services and can easily customize interaction. So we saw from Timo, and if we had more time, I'm sure we would demonstrate it even better, how the app can be customized to each individual. Of course, within reason, because as you know, too much customization brings about cost, so inconsistency in the digital health intervention. But in any case, this is there and this is important. And then the dimension of AI explainability, which, as I say, we will come back to it in about 2 months' time. We will have another webinar, so keep tuned to our social media. And then finally, enabling individuals to manage their digital health practice. So trying to involve people in this effort, and getting them on board on what we're doing with their data. And this is why the project has reached out, created an advisory board where also patients are represented, and we have had interactions with patient representatives to really understand how to better enable individuals to understand these. And then finally, digital health inclusiveness. And this is a challenge because when we talk about, for example, blind patients, all of what we've just seen is an issue. It's a challenge. And therefore, well, we're not perfect yet. And most softwares, most applications in digital health are struggling to be 100% inclusive. It is not easy. It is not cheap, but it is somewhere where we need to go. Now, making it user-friendly is important in terms of low levels of literacy, both IT literacy as well as health literacy. But also increasing the literacy level through the usage is an important factor in ethical consideration. Now, and I'm getting very close to the end. We have now done a small study. We will be presenting it next time soon if it's accepted. I'm not going to go into the detail, but we looked at different ethical frameworks. The FRIA framework, which focuses most on fundamental human rights. The ALTI, which has to do with AI development principles. And then these 16 ethical principles. As you can see, Cinderella scores quite high in most of them, but we still have some work to do in some areas where we scored partial. And then there's a 0 that has to do with the fact that the principle is quite demanding because it says digital health services are accessible by all. And all is a really terrible word because all is I mean, to cover everyone is very, very difficult. So we were a little bit demanding. But anyway, this is then my answer to the question. To use or not to use AI for cancer? Yes. To use it well. If well used, yes. If not, maybe better not to use it, because you're just creating some more problems. And first do no harm should always be our medical principle. With the right persons, so it might not be 100% applicable to 100% of the cases, and with the right support and the tools that we are trying to develop. I will try in this. Thank you very much.
Thank you, Henrique, for this great presentation. Again, to the audience, please use the Q&A function to type in your questions. We already have some of them.
Yes.
And with that, we would like to start our panel discussion. With our panelists, I would like to introduce as well, in addition to our speakers, Timo, Henrique, and Miguel. Thank you so much for your presentations. We have 3 additional panelists who are joining us, which are Helena Montenegro from INESC, Suresh Kumar from CET, and Remo Rajan from CET. Welcome also to Helena, Suresh, and Remo. We are looking forward to the discussion with you.
Yeah, there have been a lot of questions raised, and thank you very much for all your deep discussions, what you have from different directions with respect to Cinderella project. So, Henrique, you mentioned about you address a lot of ethical questions. So, let me start with you first. There have been attendee who asked, because of the new EU Act here and, US going crazy with new AI policies, how an organization can adapt, because, already all the hospital healthcare systems have some system. And on top of that, we are having now AI-based systems. Okay, so how can these both go and sync? So legacy applications, new AI applications, how effectively we can cost effectively, or from ethical sense and everything, how can we address that challenge?
Thank you very much for the question. A very good question, in the sense that indeed we need to be, let me use a medical term, a little bit schizophrenic now. We need to be able to continue using old-fashioned, non-AI, robust electronic health records, if we have them. And if we don't, we might need to still finish implementing. And I remind you that even in Europe, there are still healthcare systems and hospitals that are still paper. We still have a lot of paper in some countries. We have a mandate to finish, let's call it digitalization of healthcare by 2030. There's this digital decade aim that all Europeans have access to their electronic health record by 2030. And this has to go hand in hand with both experimentation, trials, and verification of AI solutions, and then careful implementation or not. I always like to use an expression that provokes people, which is, a pilot can end with, no, don't use it. It's not good. It's not safe. It's not good enough. Not yet. Still needs improvement. And in the IT world, we're not used to this. Whilst in the drug pipeline world, most drug companies are used to having products that never reach the market. They never go on stage, 2 or 3 on a clinical trial. In the IT world, our tradition is that we do it and people start using it, and then we'll improve it, and then slowly we'll improve it. And as long as there's a market, we're fine. But this mentality is now changing with the AI Act, with European Health Data Space Regulation that imposes conditions for electronic health records, and even the medical device regulation. All of these regulations, basically what they say is, if it is good, there's no reason why not. And I want to finish by saying, I think there's a misunderstanding that the EU regulation is prohibiting more than the US regulation. I don't think that's true.
I think it is more demanding. It might offer more opportunities for individuals to participate, to demand, but at the end, if risks are well managed, if consents are well managed, I don't see that our regulations in the European space are less enabling of an environment of innovation, where of course AI plays a role. Um, and then I think maybe we'll take a little bit longer, but maybe we get safer. And that's always the end question. You want to drive at 400 kilometers per hour? You want to drive a little bit slower but safer? It's maybe we Europeans are a little bit more cautious. Well, that doesn't necessarily mean it's bad. It just means that we don't want to put in danger the things we already have achieved. We have a very good healthcare system. Well, want to keep that. It's also an ethical value. Let's not at least go back. And I think this is important. Over.
Thank you. Now, let me come back to Timo, who has more routine medical care experience. So, as Henrique mentioned from ethical question, how regulations are changing. So, how can companies design AI products moving forward, which has to adapt to the regulation and also can be able to implement a lot of things, get it more diverse into the routine care.
Thank you very much. Maybe before we start, let me just comment to what Henrik was saying. At one point, driving speed is a very sensitive point if you consider that we are from Germany here. So we have the only highways without a speed limit.
No, yes.
Regulations, of course, as Henrik said, is something which is beneficial and needed. But on the other side, it's sometimes really a burden and a challenge for a company if it comes to demonstrate how software can fulfill all the regulations. I fully do agree with Henrik that the EU AI Act is something which is good intended, and also which is made to save people and to protect them from harmful AI solutions. But sometimes, at least on the national level, a good intention can convert into an over-control and into an overburden, especially for a company who wants to implement solutions. And that's something where we have to, let's say, be also a little bit sensitive in when do we come to a level that we are getting too many regulations. And here also something which is very common in Germany, that for everything which is somehow framework on the European Union level, we want to have an additional regulation which restricts and which also generates additional administrative work in the companies, but also needs new certifications or needs to have several new approvals by notified bodies. And we have it very well seen in the last 2-3 years with software and medical content. We already have regulations from software security on the European level, but now on top of that, from the German Internet Security Agency, BSI, we received several new requirements which goes on top of them. So just looks like that just what all Europeans find will not be enough for Germany, and therefore always getting more regulations that increase also the time to market, and of course increase massively the development cost, which at the end all of us has to pay. So if it's for medical purpose and software getting more and more expensive in the regulatory process, then at the end, all of us have to pay that.
Thank you. Thank you, Timo. Is it done?
Yeah.
Then, okay. Okay, next.
Same question maybe also to the NESC people. Sorry to interrupt you.
No problem.
Timo just mentioned that especially the Germans are crazy about security regulations, not only internet, but also data protection, etc., and that this adds to the European regulations. Miguel and Helena, are you aware of anything going on in Portugal? Like, does Portugal plan to add similar national regulations in addition to the European regulations? Have you come across something like that in Portugal?
No, not really. We are not much aware of privacy policies in Portugal, other than the ones that are demanded by the European Union.
Yeah, that sounds much more realizable. Like, because if I understood Timo correctly, it's not necessarily that there are regulations. There are regulations always, but it's the amount of regulation and the overlap and unclear applicability of regulations, especially in the world of AI currently, that is causing a lot of stress, not only to companies, but also all of the industry that comes after that, notified bodies, etc. Nobody really knows how to deal with that. Yeah, thank you for this.
Exactly. So if we have a European Union which comes to a comes to an agreement, what is safe or what is secure, we should follow that if we are a union, and not just saying, yes, that might be safe in Portugal, but we don't agree in Germany. We need a different level of security and safety, and therefore we have additional requirements. And that's not what the idea of a union is.
Yeah, definitely. There is a follow-up question. You write to this in the chat or in the Q&A section for you, Timo. It says that the published deadline for the BSI for the national security certification currently listed as January 1st, 2025. And if you are aware of any revisions coming to that afterwards, or whether that's more or less final version for the regulation so far.
Yeah, thank you. It's currently let's say really currently it's a final version. But the challenge here is, yes, it's valid since 1st of January, but we don't have enough notified bodies. So the notified bodies are dramatically delayed, and currently these BSI certification process by the notified bodies will be it's still going on until autumn this year. Also for the initial certification. Because also here the same issue happened, that notified body themselves, they have to be audited by the BSI, and that process is so complex and takes so much time that they are in delay as well.
It's crazy to imagine. Just for my understanding, if I have an AI algorithm, I develop the perfect model, and now I submit it for the to the authorities for approval. How long does it take to undergo this review, this approval process?
I mean, we are currently, exactly, the question was about DIGA. We are currently under a DIGA approval process. We started in April last year, and just the application process, and we hope to finish by March. So we're talking about April 2024 and talking about March 2025.
Okay. All right, some more encouraging topics than security regulations and waiting times for approvals.
So let me get into a little bit softer aspect of our AI. So maybe for Miguel or Helena could answer this. So this AI modules, what we use in Cinderella, especially torso mapping, is fine-tuned, pre-trained, or do you have any models for that one? And are they open source?
Okay, so in regards to torso morphing, as Miguel stated, there are 3 different algorithms. One is not AI, so one is image processing, and there are 2 that are deep learning, meaning AI algorithms. Neither of them were pre-trained or fine-tuned. They were trained from scratch solely on Cinderella data. And for more details, they are actually generative adversarial networks that are trained solely on the Cinderella data that we have gathered until with all done. And no, they are not open source. We are considering releasing the data, releasing the code that was used to obtain the models, but we will not be releasing the models themselves because of privacy issues. We cannot really share them.
Okay, and continuing with the same question, there was a question regarding what about data stored locally, processed locally, or to use a cloud-based system? Pluses and minuses.
Yeah, thank you for the question. All of our servers are local, so all of the processing is done locally in our machines, and only internally we have access to them. So we don't use cloud services and nothing like that. Everything is on our side, and we have responsibility for it.
So this back to Timo. How does Schinköthe uses? Do they use a local system or a cloud-based system?
So our system is fully cloud-based, but we manage the service by ourselves store all the data within the European Union, but on a cloud system.
Okay. Okay, and I just wanted to know also is that, or a lot of people wants to know is that, how is the patient-physician relationship, particularly from a communication and trust perspective, using AI tools in Cinderella? Is there any impact?
Asking me again?
Yeah, Timo,
Okay.
jump in, or Henrique could jump in.
So if there is an impact, we will see within the trial, because that's why we initiated a clinical trial in 5 different countries, enrolling more than 1,000 patients. And that's what we want to understand and learn. Of course, the primary endpoint is the satisfaction of the patients with the surgery, with the aesthetic outcome by being pre-trained with the AI system. But beside of that, also we want to understand how the workflow changes and how it might improve also the patient-physician communication.
Okay, so we discussed a lot of AI part in Cinderella, and I would like to ask Remo, is that apart from the AI in the mobile app, what are the challenges you faced, and how could we solve?
Thank you, Baiju, for the question. Basically, the AI part that comes in the mobile app, Cinderella mobile application, is that showing the patient how the outcome of the image is. So basically, if a physician assigns a type of surgery to the patient, they're supposed to show the details, every details regarding the surgery, and also our current picture, or I mean the torso picture, and also the expected outcome of the death. But since we have managed to communicate with the Dreno system from Inestec, and we will get the expected outcome or the expected pictures, we take it from their system and we port it, and then we show inside the app. So that was the main challenge there. Then the rest features, we managed it. That was not a big challenge, but this image showing how to show the outcome and showing the main outcome thing was the challenge. Yeah, that was from the support, the linking with the Brello was the challenge.
Thank you, Remo. And maybe next question directed to Suresh. The scalability and adaptability of the Cinderella AI application for a larger patient population.
Yeah.
How do you see that?
Yeah, thanks, Baiju, for the question. So Actually, we are using the Amazon Web Service for all our infrastructure and the servers and the services. So we can easily scale and increase the server uh, what we can say the scale we can the size of the server we can easily manage from AWS there. And also currently we are working on a cache system which will make the data flow between the system and the speed of our system will be increasing. I mean, so this we will be doing, and we will be updating our servers in the upcoming weeks.
Thank you. So there was a question from Tiago. So he asked if somebody wants to develop a AI-driven solution for healthcare, what is the secret to achieve such a smooth multidisciplinary work, one scene like in Cinderella, and achieve a final product like how we presented? So maybe Timo or Henrique could take up a little bit add, because you both were involved in the complete development from initial phase to this stage.
Yeah, thank you. I mean, I guess Henrique is also able to answer the question the same way, because I mean, the main thing we did was working together, talking together, and really doing workshops. As I showed in some of the pictures, we really met from all the countries, from all the disciplines. First, tried to get an understanding of what we are talking, how we are talking, because if you come from medicine, if you come from IT, if you come from ethical point of view, or from project management, whatever, you're using maybe the same words, the same sentence, but probably the meanings are different. And to first get an understanding within the same language, what you're saying, what you're meaning, that was very important to put all our knowledge together and to come up with one common idea, common understanding, which then leads to a common concept. I don't know, Henrik, if you want to add something here.
No. I completely agree. I was smiling because I was thinking about the first meetings in the first months, where sometimes you would say, someone would say something, and there was more than one interpretation of the same something until we sort of writing it down. So I think one thing that is really important for enthusiasts of the AI world is that AI is much more about words than numbers, in my opinion. So while there's a lot of maths in AI, and that's for sure, if you don't write it down, if you don't explain by writing what you're going to do, why you're going to do it, what are your assumptions, you want to go, what processes and what people you want to impact, different people have a different interpretation. And therefore, in another life that I lived as a digital health lead, national agency, I fought a lot with the IT development teams of documentation. And it's an old sentence. No one likes it. No one working in the IT world seems to like documentation, because people are thrilled with doing the thing and making it work, seeing it working. But then suddenly, when it doesn't, it's more difficult to go back and fix it if you don't have that document. And also, to gain the trust of clinician, especially in oncology, which is a very, very tight medical area. I'm an internist, so we live well with a little bit of ill-defined diseases, syndromes that don't even have a cause. But oncologists these days, they are bound to very strict criteria, and for good reasons, cost reasons, impact, life experience, and also death fears. So it's coming up with this trust on just at that component, and really knew from day one that AI solution is not a technological endeavor. An AI solution is a social technological. You don't have a friend from social sciences, you need to get one. If you don't have a friend who is a doctor or a patient and you're doing something for medicine, then you need to get one. And then you can start. Not when you already have the app ready or the algorithm ready, then you call them in. They're not going to like that. That would be my sort of paternalistic advice. Cinderella also, and this is to conclude, benefited from having very experienced partners. Now, this is a bad advice. Of course, if you're starting, you don't have a experience. But I want to say that this should not stop anyone from starting. In Europe, we need new projects, new companies, new startups, new research groups. But at least in Cinderella, we noticed we branched out. We went to the internet and we asked for advice. We opened our advisory board for participation. We invited experts, but we also said, whoever wants to help us, come and help us. And we had generous people coming and saying, we're happy to advise you. So even if you don't have all the expertise, there are a lot of people that are there that can actually generally help. And I think that's also very, very motivational. So if anyone's listening to us now or later, go ahead, do it, but get a group of people. Don't do it alone, and don't do it home, as they say. This is not to be done at home. Do this with others, with social environment.
Just a follow-up on this. Do you feel that civil society knows about the potential benefits and also the potential harm that AI might bring, especially in our
Yeah, I think actually sometimes we underestimate how people are interested in technology in general. And definitely, while the models are very different than capital, say now, the fact that ChatGPT and the like vaporized opinion. I mean, there's hardly anyone within the high school, university, professional world that has not experienced some sort of AI right now. And so people realize the benefits of AI. I'm not saying it's the same type of AI, and I'm being very careful with the words, but what I'm trying to say is people are more willing than I think sometimes we think they are. Which, connecting to your second question, means that sometimes they're not so aware of the danger. And they might not be prepared. They might have their defense low. So there we need to be proactively responsible. Sometimes we see people accepting all sorts of things, accept that. And we are the ones that need to be sure not to put them at the certain. But I think in general, people want innovation. I'm very optimistic in this. And when we ask patients, for example, not just cancer patients, but patients, chronic patients in general, they're always looking for something that could help them. And right now, the new thing in town is AI. This is true. This is what they call a hotline. They call their airplane company. They call Siri on their phone and whatever. And in some countries, they even have already AI services for healthcare, VR things. So it's coming and it's there. And I think they want it. What we need to make sure is that they don't get something that is not good enough. Just because they want it so badly, they might go and grab something that is not good enough. Because in the beginning, it might sound okay, but it's like these hallucination results of ChatGPT. And sometimes students put that on their exams and then they flunk because they thought it was correct. just because it was coming out of a computer. And that's not the case. Not everything that comes out of a computer is correct. And in the case of medicine, is safe. Therefore, judgment and preparing people for that judgment, that is a challenge.
I feel like Timo wants to add to it.
No, I just totally agree. I mean, some years back, we were always talking about Dr. Google, and that first opinion for a patient comes from Dr. Google, and the second opinion from a physician. And now we are changing from Dr. Google to Dr. ChatGPT, and that's at the end, as Henrik said, we want to make use out of it, and it will get a normal part of our daily life. Also, if we are from a professional point of view, we are seeing both sides and thinking about also harmful impact of AI, but it will be faster into our daily business or daily life than we might want to have, especially the non-mature solutions. And ChatGPT is not a solution which is made to treat a patient, but people are using it to get an understanding for their disease and how to cure it.
Thank you for those insights, Henrique and Timo. I would like to put it into a frame back together. We talked a lot about the algorithms now, about the technical issues, about the regulations while developing them and undergoing the certification. Now imagine you have developed your algorithm based on years of research. You have undergone the certification, which took another year or two, depending on the country you're being at. Now you have your product. You have to get it into the clinic, into the hospitals, and you have to make sure that it is used. Henrique just mentioned that an important part of the secret sauce, how to make AI successful, is also to get the trust of the patients and the doctors. And we already heard that patients might be relatively open to using AI or seeing it as part of their treatment process. What is your experience in terms of the clinicians, the doctors, the nurses? Are they a population that are relatively open to using AI or relatively strict and skeptical about AI? What are your experiences here?
No, it's for me or Miguel or Henrique.
Whoever would like to share.
I can start. Clearly, it depends. There's a lot of factors, but that is very comparable to other situations. So we have early adapters, physicians, and it's mainly very often it's nurses also if they have time, and that comes as the next factor. So healthcare professionals who are early adapters, who wants to understand new things and who are eager to work with new things. And then you have on the other side, you have especially quite often elderly physicians who are well experienced and they are doing their things since decades and they know how to do, and there's no need to improve or to change because what we did in the last 20 years was good, and therefore it's also good in the upcoming 20 years. So there are different behavior like in the private situation, also in the professional environment. But then, of course, a huge factor is the healthcare environment itself. So do the participant have some freedom, some space to look into new things, to make them familiar with new things? Or are they so much in a cave to just run after what they have to do? And that's also from our experience something which gives a lot of impact to being open or to keep open-minded. So if you're with your daily business already struggling in how to complete your daily work, you don't have the time to to think about new things and to make you familiar with. Because if you have a transformation process, transformation always means additional workload during the transformation process. And for that, you need the resources. And if you don't have these resources, there's no chance. Also, if you're an early adapter, there's no chance to really make you familiar, change your processes, and implement the new solutions in your daily business.
I would also compliment, I agree with Timo, and I guess maybe Miguel could tell us, who was behind Berlo? It was a doctor or it was an IT person? Who asked for that type of solution? And you get an answer there for your question. But I just want to compliment by saying also there's this dimension of medical liability. So if the solution is seen as something that complements my thinking, but I'm still the responsible, then it's easier to implement it in my day. But if it is something that is there to supposedly sort of substitute a little bit my decision, then I think we are seeing a lot of resistance. We're seeing a lot of resistance, and maybe rightly so, because maybe we're not pure and reliable. And in general, most clinicians are conservative. So they're okay to change from drug A to drug B when they're really sure that drug B is better. Unless there's no option, there's no other, there was no drug and now there's something. In that case, they are willing to try out something. But in general, so the incremental innovation is perhaps more the model that see in many mindsets of healthcare, in even healthcare organization. And with this, I want to go. It's not just about the clinician, nurse, it's also the environment, the hospital itself, the healthcare facility. Because if these systems require access to this or access to that, connecting to the cloud, or sometimes it's actually the non-innovative spirit, the IT development of the IT director, or the hyper-conservative or hyper-safe cybersecurity guy or girl that reduces the capacity for the others to experiment. And we see this when the solutions are possible via mobile phone, when the clinician can download to their own personal device. There, it's only about his or her willingness to adopt the early adopter. When the solution is, for example, connected with the EHR, it has to be connected to the organizational IT environment. It's not just clinicians that have to be proactive and innovative. If the IT sector of the institution is also not willing to do it, they find easily a way to form patient. So it's a combination. This is why I very strongly believe that we need to talk to what Americans tend to call it chief medical information officer. So a doctor or a nurse that sits beside the IT director or the chief information officer, and really says, you know what, this is interesting from a clinical perspective. Please go ahead and get us this thing to help. And those educating those people as enablers is important. Because otherwise you might have a bunch of doctors and nurses that want to use it, and the patient want to use it, but then there's one person that blocks the firewall or blocks the data protection authorization, and that's enough to not
to shut it all down.
Just make everyone a little bit depressed about it.
I think that's a very important point. It's not only about the people, but the infrastructure, especially also here in Germany. I would have never thought I would learn to operate a fax machine, but I do so in the hospital now. And it's not an easy thing. It's not a given thing that the infrastructure is there to accommodate complex and modern AI algorithms. Yeah, definitely true. Maybe if I could come back to one of the points in Timo's and Henrique's presentation that we touched briefly on, is the feeling that the doctor must keep control over the AI, that the doctor must be in the driver's seat in order to feel comfortable to use it. But on the other hand, Henrique mentioned and introduced us to the concept of AI being a black box, not having an understanding directly into what AI is doing. And that to me as a physician often causes the feeling, what should I do now? Sure, as a physician, I probably have the responsibility by law to make the final decision, even if I use an AI algorithm. But how am I supposed to understand an AI algorithm that nobody actually understands because it's a black box? That often feels very contradicting to me, and I don't see a solution there yet to me, except for, and this is my opinion, saying that I, as a physician, I also don't understand perfectly how an MRI works, but I rely on the MRI being certified by giving valid results because this has been checked by other people and regulations. But I'm looking forward to your experiences and opinions here. How do you solve this contradiction? Doctors feeling comfortable keeping the control over the AI, but on the other hand, nobody really knowing in some cases what the AI is doing. Timo and Henrique and Miguel, Helena, what are your opinions on that?
May I? Okay. So in terms of AI, well, there is a field of AI that is called explainable AI. So not all algorithms are black boxes. So the field is going towards having algorithms that are both explainable and that can be helpful to clinicians. However, there's also contradiction there, because if the AI provides an explanation, there are some studies that say that, well, when the AI is wrong and if it provides a convincing explanation, then doctors are usually misguided by the wrong answer, and that in itself is dangerous. So the field is still open. There are still issues there. And that's why, going back to a previous topic, we do need to be very aware of both not only the benefits, but also the dangers of AI. But because AI can also be weaponized. And within the context of Cinderella, one thing that I wanted to bring up was that, for example, we are generating predictions of how the patient will look like after treatment to help the patient decide which treatment course she wants to get. However, there is the danger that the patient may look at the pictures, select one type of surgery, and after the surgery, the result is completely different. And that, in that case, the patient may be able to use the AI as a weapon against the doctors, against the health institutions. And that's why it's very, very important for patients and doctors to be very aware that there are limitations in AI. AI is not entirely trustworthy. It's not God. It doesn't know the future. It only predicts some probable potential future, but we do need to be aware that it might be wrong, and it can be weaponized. It can be dangerous. So that's the point I wanted to bring up to the discussion.
I mean, I feel that AI needs some time. Consolidation will happen in the market. It's like the first calculators came. Everybody said mathematics jobs are gone. So we need to be more patient and work with projects like Cinderella to see what is the real outcome, to take the trust of the healthcare community.
That's an important point, yes. Henrique, do you feel like a doctor has to keep control over AI in order to make informed decisions in the clinic? Is that something you can ask of a physician?
I think there's a lot of debate on that. For example, in Portugal, the Medical Association is revising their deontological code, adding for the first time a bunch of articles on AI. And in one of the articles that I disputed, as I was invited to comment on last week, is that at the end, the responsibility is always of the doctor. This is a little bit a little bit too much, maybe to us. We have, even in the medical legal world, we have developed mechanisms of liability that are what we call faute de service. It's an expression in France, which means problem of the department. It's not a person's fault. It's a whole process that was not that didn't go well. And I think as we move to a more AI-based healthcare, this will happen. So it might be that it wasn't the fault of the algorithm. It was maybe the data that was fed to the algorithm that was not good enough. Maybe the subsequent interpretation of the response was faulty. So there's more than one reason. So I think it's not in the interest of doctors to fight for getting the sort of the end responsibility that might go against them. And also, there's a personal opinion. I mean, I did a master's of this slide. Anyway, my point being that it's too much to ask from a person all the responsibility for the outputs of something that was developed by many people. In this webinar, I think it is very clear now for everyone. In order to get to an output, that you get programmers, mathematicians, algorithm developers, data curation, and so on. Many things can go wrong in this chain. So why is the last guy or the last girl to take all the blame from this chain of events? That's not in his interest. And so I think we need to move to shared responsibility model. And I think we are seeing that more and more. And to conclude on this is not new. I mean, right now, even in the drug world, you may be liable from having used the wrong dosage, but you're not liable because, for example, the product had some sort of problem. But in order to separate who had the problem, there is a regulator that checks the quality of the product per se. And then there's someone, sometimes even a different regulator, that would go into your records and see what was the dosage that you have prescribed. And this is exactly to try to solve the problem of shared responsibility. So complex things require complex solutions, unfortunately. And we just have to live with it. AI is a super complex thing. It might look super cool, but it is super complicated.
I think that's a great final quote and remark of this whole webinar. AI is great, it's interesting, it's super cool, but it is enormously complex, and there are still a lot of things we do not know yet. I would like to thank all of you for attending this webinar. It's 4:30 actually already. And I hope that we could give you some insight in the kind of multidisciplinary work in the amount of work, research, and the kind of people that are required to make such a project possible and feasible. And that you have learned that there are a lot of things we are getting better at, the development and the certification of those algorithms, but that there are also still a lot of aspects we have to learn about AI, especially medical AI, in terms when it comes to the actual clinical implementation. Who is doing it, who is willing to do it, who is liable for it. And these are questions we're only able to answer by doing such clinical trials and by learning in the future how this will evolve in the clinic and in the hospitals based on the feedback of our patients and clinicians. So again, thank you very much for attending this webinar. If you have any additional questions, I guess our speakers and panelists are more than willing to answer them afterwards. And we're looking forward to seeing you in the next Cinderella webinar, which we will announce via the usual social media streams again. Thank you very much. It was a pleasure to be here with you, with Baiju. And thank you again to all of our amazing panelists and speakers. Thank you. Have a great afternoon and see you soon.
Thank you, André.
Thank you and goodbye.
Bye. Thank you.